Trusit Dave is all set to go.
The thing is, I need to say thank you for saying my name properly, because as you could probably imagine, with a name like Trusit with Dave written at the end, I'm called a whole combination of different things, and it is Trusit Dave, and thank you for getting that absolutely right. I thought this morning's session was really, really interesting, even from as a patient, I can't imagine, but as a clinician, for me, it was really interesting because of the research, because of the genetics, but the AI. And I was at a conference just a couple of weeks ago at the International Myopia Conference in Rotterdam, and there was a lot of information on AI. The reason why we're interested in AI is because, particularly in children, myopia, if we could predict myopia before it happens, we can slow it down. And so these researchers found that just by looking at a photograph of the back of the eye, a technology that's freely, available throughout the UK, in most high street practices, they could predict with a reasonable level of sensitivity and specificity myopia in a child 5 years before it actually even happened. So you can imagine that if we push in this data, relevant data, into an AI model, it's kind of like a black box system. You don't know how it's calculated it, but it then tells you associations. There is a lot of hope for keratoconus in terms of early detection. So, as we were just told a moment ago, my talk is a little bit less on the research side, more on the clinical side, but with some emphasis towards the end about how new technologies are emerging, something we're doing some research on in our practices to improve vision, because that's where I come from. My research was all about understanding vision, a term which I'll use throughout, it's called aberrations, and how we can quantify these things in a condition that principally causes one problem, a reduction in vision. So, as my predecessors have done, probably have defined keratoconus, but unfortunately, my video isn't working. So maybe we could just restart that slideshow, and then I can show you my wonderful videos, because that would be great. Can we do that? In the meantime, I can continue talking about keratoconus. So, there we go. That was instantaneous, so well done, AV guys. What it is a condition that's not just related to the distortion. We call it an ectasia because ectasia literally means thinning. So you get a thinning within the portions of the cornea, usually centrally, which causes this, as we've learned this morning, displacement of stromal fibrils, loss of stromal fibrils, and a weakening. And primarily it causes a reduction in vision by virtue of that change in shape. Now, particularly at night time, if the pupil gets bigger, you're seeing through a more distorted area, hence why most patients with keratoconus really find night vision really, really problematic. So those are the reasons why. Okay, so why do we use contact lenses? Why do patients, and some people might say contact lenses may even, the rubbing on the cornea may exacerbate keratoconus. I'm not quite of that belief. But why do we use contact lenses? And there's only one reason why we use contact lenses in keratoconus. It's to make the vision better. It's not to stabilize keratoconus. It's not to slow it down. It's to make people see better. So, how much better? And so we can have a little bit of an education on what I call the vision fingerprint, because two people with the same optical prescription in their spectacles actually see very differently. One person might get halos at night. One person might get starbursts, another person might get glare. Yet they have the same optical prescription in their spectacles. That's because of this technology, that's because of we're not measuring the subtle refinements that create those visual distortions, or dysphotopsias as we call them. Now we can measure them using a technique called aberrometry, and there's a variety of methods that we can use. So we can quantify these, and then from that information, we can break down that measurement into its individual components. So it's a bit like, the analogy is a bit like this. If you imagine you wanted to create a portrait, you'd start by doing an outline sketch. That might be a baseline measure. Then it still wouldn't quite look like that individual, so you might put some lowlights, some highlights, some further refinements, shadows, And then ultimately, with the more subtle things you put in, you're able to see a resemblance of that actual person. Likewise, with aberrometry, we can break these maps down into the fundamental components of vision, and they look like this infinite series of terms. That pyramid just keeps going further and further down. Now, if you wear spectacles, then those top three that you see, astigmatism, sphere, and another a portion of astigmatism, they're essentially the same thing, but just in different directions. That's all we can put in spectacles. That's all we can put into soft contact lenses. And that is the reason why keratoconic patients do not see well in spectacles if they have these other series of aberrations, like that second term, that second row in the pyramid. Keratoconics are notorious for having very high levels of what we call coma or chromatic aberration, not to be confused with a coma. Chromatic aberration, it's a description, okay? So these are the optical parameters that are very high in keratoconic patients, but not in non-keratoconic healthy eyes. And that's why most people who don't have keratoconus see perfectly well in spectacles, because these other smaller refinements are just not significant enough to be corrected, okay? Right, so how much of a difference is there between these aberrations, which I call coma? And there's been quite a lot of research done in this, and if we look at normal eyes, then you can see it's quite small in terms of coma, which is the first one on the left in this graph. If you compare it to a similar group of keratoconic patients, you can see how much difference there is in coma. And remember, that's not correctable in soft lenses, and it's not correctable in spectacle lenses. This is why we have to use a rigid lens, or what creates a new rigid surface. So this slide is showing you a measurement of aberrometry. So this is not like your topography maps that you may well be used to seeing, where you have a similar color-coded pattern, which is telling you about the shape of the front of the eye. This is telling you about the optical imperfections, and we use a similar type of qualitative description with color-coded maps. Basically, if you saw one color on that map on your right-hand side, then that would be perfection, okay? When you see this asymmetry, the oranges and the blues, that tells you that there is an aberration that is not correctable in spectacles. So the dotted pattern you see there really displays the way a perfect grid would be formed through a keratoconic eye. And you can see it's not a perfect grid, it's distorted. So those would be light rays that are coming out of the eye and how they form. And that's pretty distorted. But the great news about this technology is we can simulate what keratoconic patients see. And I find this is really helpful, because when I have a patient in the chair, I think, and all of you may attest to this, sometimes you feel like you're saying something and the person who's fitting you or examining you just doesn't understand what you're seeing. And and this technology goes, I mean, it's not perfect by any means, but this technology allows me to show patients that I do understand what they're seeing, and actually objectively show them that changes in what I'm doing are having a positive effect on their vision. So, what happens on that same eye when I put a rigid gas permeable contact lens on? You can see the contact lens there with fluorescein, so we can see the fit of the lens. Now we've done the same ray tracing through this eye, and you can see it's now much more like a grid. The lights, the individual points are much more vibrant, which tells you the intensity is greater. The focusing ability of the eye is much improved, and you can see the map on there is far less, there's so much less disparity. And again, by simulating what patients see, you can see that right at the bottom, which would be like a 20/20 letter, you can discern that. But it's by no means perfect, because even on that letter at the bottom, you're seeing what many of you are familiar with, which is that second split image, that overlapping that is so bothersome for you, particularly at night. So not even the rigid gas permeable or the scleral lenses, any of these lenses that form a new surface on the eye are actually correcting 100% of these imperfections. In fact, if you theoretically calculate it, it's around about 90% for the front surface of the eye. And I think it's important we understand that keratoconus is not a disease that just affects the front surface of the eye. In fact, most of the detection of keratoconus early on is when we start looking at the back surface of the eye, and we start looking at the thickness of the cornea and how that changes. So that's why when we look at this research again and look at real patients, we find that in reality, these rigid gas permeable lenses are not 90% effective in correcting these aberrations. They're only about 65% corrective of those high-order aberrations. And that's because of what's going on at the back of the cornea, okay? Not just the front. So what's stopping us from a great deal of success with rigid gas permeable scleral hybrid lenses? Some of the things have been covered already. Atopy, allergy. Patients wanting to then rub their eyes even more, which we know is associated with higher levels of progression. We shouldn't forget about infection, because contact lenses are also associated with higher rates of infection. But what everyone here should understand is that that risk, particularly for rigid lenses, is very, very low. And a take-home point for every contact lens wearer: never use tap water with your contact lenses, never shower, never swim in your contact lenses, because the risk of getting certain types of infection is significantly higher just by virtue of adding tap water into that regime. Okay, so other factors working against us: dry eye disease. And it's really important that whoever you see for your contact lens management is also able to manage your dry eye problem. There are a number of improved methods of treating dry eye. It doesn't just mean drops all day long, and there are lots of different drops too, lots of different formulations. It's also activity, environment, and what's making dry eye much more prevalent now. It's because of the digital devices we're on all day. We blink far less. When you're on digital devices, after about 20 minutes, you blink 2.5 times less. You make 2.5 times more incomplete blinks, and you can blink up to 10 times less. So it's a huge impact on the wettability and the surface of the eye, which you want to keep healthy. So managing dry eye disease and the prevalence of dry eye disease, almost 50% in keratoconus, and in the general eye population in this study, about 29%. So keratoconics disproportionately suffer more with dry eye disease. There are, as I said, a lot of treatments out there for keratoconus. My video needs to play again, but we'll try if this works. Let's see if that makes it work. Maybe not, but it would be useful to get that video playing. I'm going to be a thorn in the side of our audio-visual engineers, already having been the person that's had their slides incompatible because I use a MacBook. If we just go back one slide, please. Right. Of course. Sure.
With keratoconus, the contact lens that is going to go onto the eye, does the lens, is it shaped to fit the curvature that is on the eye, or is it shaped to push the shape of the eye back?
It's never should be designed to push the shape of the eye back, okay? And yes, I'll repeat the question. So the question was, with regards to contact lens fitting in keratoconus, should the lens be fitted to match the curvature of the eye, or should it be fitted to almost squash, almost like braces are for to straighten teeth? And my answer to that was that they should never be fitted to squash the cornea. Okay, that's definitely not what we want to do. But as far as your first part of your question was concerned, was should they be designed to align with the eye? Well, it depends on the type of lens you're fitting. If it's a rigid gas permeable, those small little diddly lenses, then yes. But with scleral lenses, as you'll see later on in my talk, no, it's quite different. So what is the holy grail? And I think the holy grail of vision management is no contact lenses at all. Okay? And that can only happen if we detect early. And that comes back to what the previous speakers were talking about. early detection. And in terms of, I heard a lady ask a question about pentacams in the community. I think that's not going to happen, but there are plenty of optometrists with topographers, plenty of optometrists with OCTs, which can take sections through the cornea and look at the back surface of the cornea. So I'm not that negative about it. I think that type of healthcare is available in the community, and you need to find your specialists in the community. That's really, really important. Okay, so actually now the video appears, and this really just illustrates the type of other treatments that are available. It's not just related to tear volume; it's related to the oils in your that are produced by the eyelid. Those oils get blocked within the glands, and those oils are responsible for reducing evaporation. In our clinics, we do these sort of treatments as well as the drops and other formulations that we can give, and expressing those oils out of the glands is really, really important. Next slide, because I can see people almost about to collapse on the floor. On to the topic of contact lens management. So you might say, why hasn't he put a soft contact lens on there? For very good reason, because I said to you early on, the number one aberration, the number one cause of vision reduction, cause of that splitting of light, is this thing called chromatic aberration. And soft contact lenses do not correct that. They just drape on the eye, okay? So you're not even going to get any neutralization from a soft contact lens. So I've put in 3 options there. A hybrid lens which has a central rigid gas permeable portion with a soft skirt. That's option 1. Option 2 is the tried and trusted rigid gas permeable lenses. And then option 3 is our scleral lenses. So when do we use each one? Really, nowadays, I'm straight onto the sclerals. If I'm absolutely perfectly honest with you, I go straight to the sclerals. I hardly do much hybrid lenses unless the patient specifically requests them. And primarily it's for those people that are on rigid gas permeable lenses, they keep losing them, or they just don't want a scleral lens. And that really is inside here. Okay? It's for some people, they see the the scleral lens and they think, I can't do this. But once they practice and they learn and spend as much time as possible, it truly is a revelation for people in terms of how much comfort there is. So I'm very grateful for rigid gas permeable lenses. They served a purpose for many a decade. Optically, they're great. We can also do lots of changes to the front surface and the back surface, so they're superior to these hybrid lenses because we can do many more changes in terms of the fitting and vision correction. But when it comes to sclerals, I think we solve a big issue, which is comfort, okay? And stability, because they don't move around like rigid lenses. They don't flick out of your eyes. So some of the problems with hybrid lenses, yes, they improve comfort, they improve the centration of the central portion of the lens, they correct your vision, but remember, only 65% of those high-order aberrations, those imperfections are going to be corrected. They're expensive, you have to be changed every 6 months. The peripheral soft lens material is made out of an ancient material which we used to call HEMA, very low oxygen transmissibility, and if you're one of the unfortunate people who develop vascularization, that's not something we want when we start to future plan and say, look, in the worst case scenario, if you need a graft, do you really want vascularization in your cornea? Of course we do not. We want to avoid that with every bit of force that we have, or energy that we have. So there's also optically a couple of disadvantages. You can't correct residual astigmatism, which happens with a relative degree of frequency. Our rigid gas permeable lenses, as I said, served us well, but what we don't want to see, they sit on the cornea. Coming back to this lady's question is, do you want to align with the cornea? With this one, most definitely, we want to align well. But can you do that on a keratoconic cornea? The answer is, you cannot at any given time align with every portion. And bearing in mind that that lens is moving, in a dynamic state, it's never really going to be in line. So you're always going to have pressure points on the cornea. And what we want to avoid is staining, which is what you see, the green central area is where the lens has been rubbing, it's bearing on the corneal surface. that is what is prone to gonna be scarring, okay? We don't want scarring. If you have scarring, have it in the periphery. You don't want it in the middle, because that's when your vision drops very, very quickly, okay? So we don't want that. So that's some of the problems with rigid lenses, and notwithstanding the fact that, you know, you move your eyes to the left very quickly and have a blink, and you've all been there, you're looking for your lens on the floor trying to find it. That's one of the downsides of rigid lenses. I can see so many people sympathizing with that, and I do have sympathy with you all as well on that. That's one of the reasons why they flick out. So you can see, if you imagine the cone is decentered inferiorly, this lens will center about where the cone is positioned, because it's on the eye. And so that lid just needs to come down and blink, and out it pops. Okay, very easy to understand why they come out of your eye. Okay, so my flavor of the next probably 5, 10, 20 years is a scleral lens, and they've come a long way. Why do we prefer scleral lenses? Well, they never touch the cornea. They land on the sclera, which is the white part of the eye, and in between the sclera and the cornea is a liquid lens, so it never should touch the cornea. Of course, now you see there's a new surface, and that forms a new regular surface to focus light. But remember, these two do not correct 100% of those imperfections. So many of you with scleral lenses say, well, my vision's pretty good. Great, congratulations. Some of you will say, well, I've tried them and my vision wasn't quite as good as I expected. And we're going to talk about that in a moment. How do we assess them? The optometrist puts them into your eye, filled with a fluid with a dye in it, and what's important is he or she will be looking at the front surface of the lens, the back surface of the lens, and the gap between them, which is denoted by that green bar going from top and bottom. And we scan from what we call limbus to limbus, which is the edge of the colored part and the white part of your eye, right the way through to the other side, in order to make sure the cornea, the lens is not bearing on the cornea. When you put these lenses in, that very moment, the level of difference between the back surface and the cornea will change from the moment you put it in to half an hour later. So your optometrist will need to account for that during fitting. So I often either make the patient's life very uncomfortable and keep them there whilst I'm doing the fitting, and that sometimes works well for people traveling long distances, or we've become pretty good at understanding how much of a change there's likely to occur on average, and so we just predict that amount and account for it. As with all of these things, there can be complications, so it's important that we check for those. So the first thing is making sure it's clearing the cornea. The second thing is to assess how the periphery of the lens lands on the white of the eye, which we call the sclera. And I'm showing you the kind of rudimentary ways of evaluating this, because what I'm about to show you is the much more sophisticated high-tech methodologies that we now can use to evaluate these things. So, but this is a pretty good test. Just by indenting on the sclera, you get an idea of how loose it is. Movement, these lenses don't move much, but seeing how those blood vessels move from outside of the lens to inside of the lens is a really good way of seeing whether the lens is impinging and pressing on the sclera, and that would indicate, obviously, we need to flatten the edges somewhat, okay? So what are the complications? Well, this is an easy one to fix, blanching, where we're looking at the edge of the lens and outside of the lens. You'll notice outside of the lens, you see the normal redness of the eye. Inside, immediately, you see a white area, and that's because the lens is squeezing on those blood vessels and taking out the blood supply from there, so it's blanched. Hence why that would be a lens that is too tight on the eye. Other things, this is a bigger problem for patients, and you'll read this on the forums. Yes, we as optometrists and ophthalmologists do look at the comments that you're placing on the Facebook forums. We don't always reply, and sometimes there's reasons why we can't reply to those comments. But I do see many a time people saying my vision's getting worse after half an hour or an hour of putting these things in, and that's usually because of a build-up of mucin. That it shouldn't really be as quick as that. You know, I can understand after 4 to 6 hours people needing to take their lens out and refill it and put it in, and you don't need to have an hour's break in between either. You can literally take it out, refill, straight back in, okay? I don't tell my patients to keep them out for long periods of time. Usually when you get a mucin buildup, it's a fitting issue when it happens particularly quickly. It can be because the edges are too flat, the clearance from the cornea is way too excessive, and those are the typical reasons why, which can be remedied, okay? So it just needs to be seen by the clinician to apply the remedy. It's not something that is non-treatable. Sometimes I've seen pictures online where people say, what's that white stuff at the bottom of my colored part of the eye? And that is usually something called conjunctival prolapse, where the loose conjunctiva has been sucked in under the lens. And that skin, it's not dangerous, it's not going to harm the patient, but it's preferable that we do not have excessive amounts of this. Again, there are strategies that we can use in terms of modifying the fit of the lens to reduce the amount of conjunctiva that's been drawn in. Usually, it's because, as you see on the, so what the top image is showing you is a green line with an arrow pointing down. And what I'm doing is I'm using a particular type of technology called optical coherence, or OCT, but this is not applied to the back of the eye, it's applied just in that direction. And what it does is it gives me a slice through that area. And the bottom image shows you what that slice looks like. The faint grey lines at the top of the image, which are very difficult to see, show the front and back surface of the contact lens. And then the bright area shows the eye. And that little bump you see is the conjunctiva being drawn under the contact lens, okay? So it is something that we can fix in this instance. Again, using the same technology to refine our fitting is also possible. So when I want to clear the cornea, we do not want excessive clearance because that will promote more fogging, okay? So we want around about 50 to 150 microns of clearance. So a micron is, we're talking about 100 microns is 1/10 of a millimeter. So you can see that's the sort of level we're working to. And so what you see on the top image is a keratoconic eye where the scleral lens is pushing on the cornea. We do not want that. The bottom image shows the edge of the scleral lens where we can see how it lands on the sclera. We could check the angle if it's too tight or too loose. That's actually pretty good because the conjunctiva is just halfway up the edge, which is a fairly nice endpoint, but we're also looking at the angle with respect to that. So what do? Well, we can change the height of the lens, and the top one is where it's excessive. I dropped it by 300 microns, and now I've got something like 61 microns of clearance at the bottom. After 2.5 hours of wear, I'm quite happy with that. It's not going to go any further down, and it's not going to touch the cornea. So modern-day technology is really, really useful also when you're in the chair and you're sat there with your optometrist and clinician. You're able to take part in that discussion and understand exactly what is happening to the lens. Okay, so on to the exciting part, if you thought that wasn't exciting, is what are the newer innovations? As I said to you earlier, I come from a perspective, from a research background of understanding vision. So is there anything that we can do to optimize these lenses and not just go back to the days where we're indenting the eye, moving the blood vessels, seeing what you can see, adding another -2 onto the lens and saying, you can see. That's the best we can do. In fact, it turns out there is. So first is, can we individualize the fit? And we've been able to do this actually for the last 30 years, I think, because I remember sitting in with my mentor, Tony Sabel, many, many years ago and taking impressions. That was customized. But can we do it without doing impressions? Can we make lenses to a high degree of accuracy through new lathing technology that can match the shape of the eye? So one thing we are now able to do is measure the shape of the sclera, not only the cornea, okay? And what we've learned from that is the scleral shape is incredibly variable. It is, all of us, and we can't even predict it from knowing what an individual corneal topographic map looks like. There is no correlation. And the other reason why it's important is because the fit of the lens also affects the vision. So many of you will anecdotally been saying, I've had a really good fit in the past and I could see so much better, or my previous lenses were fitted differently, but I could see better. It's not always that the best fitting lens gives the best vision. Sometimes it can be the opposite way around. Okay, so what this technology, another video for my sins, does is gives us a elevation map and a height map of the whole sclera. I'll try pressing that again, but it didn't work. I don't know why. MacBooks are meant to be the most reliable things in the world. Clearly not in this instance. What we get, and this is what I can show you, is the type of output. Similar to those height maps you get in corneal topography, we get these elevation maps with scleral profilometry. Now, what we've learned is that scleras are rarely round. Now, you see that red circle? That red circle tells you the junction between the colored part of the eye and the white of the eye, okay? So basically the edge of the colored part. Everything beyond that is sclera. So we can get anything from 16 to 20, 21 millimeters of scleral shape. And this is to illustrate that this is an uncommon finding. Round scleras, not that often. You won't get them. And yet, when you order these scleral lenses on a basis of just qualitative fitting and just following the instructions, the assumptions are that the sclera is round. And then you have to modify the edge. Most scleras are actually toric. In other words, they're steeper in one portion and flatter in another portion, usually 90 degrees to it. So you can have scleras like this, where, and by the way, these colors are back to front to a power map, where the red here indicates that the elevation is, that the sclera is flatter, and the blue indicates that it's steeper. You can have them like this, you can have them the other way around, 90 degrees to it, and you can even have oblique ones where you can see it's blue going obliquely and then it's sort of redder 90 degrees to it. And all these things mean that the shape of the sclera is individual to all of you, pretty much. And then you even get scleras where you actually have quite an odd perspective, where just in one portion it's got a steepening or a flattening compared to the rest of it. So lots of permutations. So when you're fitting a scleral lens and landing just on the sclera, it makes logical sense that we need to understand what its shape is like in order to get the best fitting. Okay, what about the most important thing? What's the most important thing for all of you? Vision, exactly. How can we individualize vision? Can we do that? Is there any hope in the future of doing that? And I recently invested in one of these machines called an eye trace. Okay? It's kind of the latest and greatest way of understanding a patient's vision. And what it does is it sends 256 individual beams of laser light, low-powered laser light. We're not aiming to fry the retina or anything like that. These are very, very low-powered. They form an image on the retina which we're able to interpret. Now, on the left-hand side, which is a keratoconic eye, you can see the retinal spot pattern. That's the dispersion of those rays on the retina. The one after that is a normal eye, just happens to be my daughter, who's sat at the back. Pleased to say she doesn't have keratoconus. And you can see how perfect a young eye can image those individual rays. And from this, we can do something quite clever, which is tell you how you're seeing to an even greater degree of accuracy than we've ever been able to do before. So we can determine that splitting and actually combine all this information to create a customized lens. This slide illustrates the effect of a keratoconic patient with two different scleral lenses fitted slightly differently. The powers were the same, so we worked out the best prescription for that contact lens. But yet the fit resulted in a completely different visual outcome. So this fit resulted in much better vision than the other scleral lens. Okay, so fit does affect vision. Okay, and by the way, the patient concurred with these simulations as well. So what are we trying to do? Well, we're trying to combine these two innovations and get the information on the shape of the eye as well as what the patient's seeing to try and customize vision and fit for that individual. Now, I apologize for the ridiculously small numbers there, but there's a reason for that. What these numbers show are the many, many terms that this technology analyzes, which is beyond just the two parameters in your spectacles, which are sphere and cylinder, which basically correct your myopia and your astigmatism. And I want you to look at the top one, which, we'll start with the bottom one. This is a patient who's got keratoconus and already has a scleral lens on their eye, okay? So when we look at the front surface of the cornea, we're able to see whether there's any imperfections. Well, there shouldn't be, should there? Because we've got a scleral lens, it's made a new surface. And so we see very low values in this area. And if the scleral lens is doing a great job, the overall quality of the image should be very, very good. But when we look at this one, which is total eye, you see those red bars? Those red bars are pointing to a term called coma. We're back to that same old word again, coma, which is that imperfection that is very, very high in keratoconus. So that's residual to the fact that the contact lens is on there. And that is because of the internal optics of the eye, which is the back surface of the cornea. That's what's causing it. Can we remedy that? Because I have hundreds of patients who simply wear scleral lenses and are just teetering on that legal limit for driving, and I can't get them any better. Can we get them to a point where you're not just barely able to pass that limit, to comfortably getting there so that you're confident? So here's a new technique. By the way, this is what the patient saw. You can see the C there, and you can see it split. And that, again, was corroborated by the patient. So this is a new type of lens design, which is still a scleral, but corrects and compensates for coma. Okay? So, and you can see that because if I go back to the previous slide, the center, the color-coded map there, is one color. With this one, the color-coded map varies to correct for coma. And what you also see here, if we go back to the cornea, we've induced coma, but it's not red, it's blue. It's in the opposite direction. So guess what that does? Opposites, what do? They cancel each other out. So when it comes to the cornea, we're in the back of the cornea, we've cancelled it out. So when we look at the overall aberrations, you're looking for the red here, and it's pretty much gone. So they're able to see better. Now, it's not 100%, and here's the advertisement. I'm doing a pilot study on it, okay? And we want to roll this out to do a much larger study for doing this, to try and really establish where we can create this design and offer it en masse to patients, which would be a great innovation in terms of optimizing vision even better. So, this technology also tells us when a contact lens isn't required, because sometimes I get referrals coming in and they've been diagnosed with keratoconus and it's like, this patient needs a scleral lens, rigid gas permeable lens. And I've, in the past, even tried fitting them and it's been disappointing for the patient and disappointing for me. We see the ray trace, we see some dispersion on the retinal map. When we look at the simulations, we see the topography map is typical of keratoconus. But if I bring and make this a lot bigger, so you can see the coma of the cornea is in one direction, the coma of the back of the cornea, it's inverted. In other words, it's correcting it. And that's why, when you look at the overall eye, there's very little coma. So this is just a very fortunate situation for this patient, where if I happen to put a scleral lens on, and I actually did because I just wanted to prove that my technology works, actually did cause a significant reduction in vision. So it's nice to prove to the patient that this is the reason why it doesn't work. And so what do we say to our patients? Well, go back to your good old-fashioned spectacles because they're doing a great job. Okay? So sometimes we do need to say that. So in summary, when do we use contact lenses? We use them one reason, to improve vision. There might be some cosmetic reasons, and I'm going to sort of put them in the back burner. There are other reasons, but medically, it's to improve vision. For me now, scleral lenses are the preferred option for virtually all ectasias, keratoconus, PMD, all those kind of things. Even post-graft, I'll use scleral lenses. Take-home point is that no contact lenses will slow down the progression of this disease. That's important. You need to have cross-linking to do that. And to do that, you want to have that as early as possible, as soon as possible. Corneal staining is something we want to avoid. And the innovations in technology mean that you can be part of that consultation and understand what we're doing. And the future of technology is now allowing us to go beyond just sphere and cylinder, astigmatism and myopia, into correcting the real culprit in keratoconus, which is coma. That's the thing that causes these multiple images, this splitting of light, doubling that you're getting, and now we can aim at correcting that. Thank you very much.
Fantastic. Is this on? To have someone that seems to understand what we're going through. I mean, your description of sitting in the chair, trying to describe what you're seeing and just getting a blank look. And I mean, admittedly, it was in the 70s when I used to have that situation. I mean, they just didn't understand what you were trying to describe, exactly what you were showing. And you think, oh, they're not getting this.
Do you know what I would do if you ever get that problem happen again? You just get them to turn the lights off in the room, put a little light on, and tell them what you see. Because back in the old days when we didn't have this technology, I used to even get patients to draw what they see. And that light source in the room is your aberrometer. So these machines cost about 60, 70,000 pounds, okay? They're not cheap, so they're not going to be available in the community. But if you just draw it out and say, this is what I'm seeing.
Well, yeah, you get a starburst coming out the side.
Right, and I often say how bright it is, how far it extends, and those things are really useful. If that doesn't create a red flag, then you need to decide what you want.